how are you doing? I hope you are doing well. And today our lecture is chronic kidney disease. Why this topic is relevant? First of all, we will consider today its world epidemiology relevance. We will revise knowledges about kidneys and its function, and then we work strictly with chronic kidney disease. We will consider its definition, pathogenesis, classification, causes, clinical signs, diagnostic and treatment methods. So let's consider why this topic is so relevant. Have a look on the slide showing us world epidemiology of chronic kidney disease. It is shown analysis of global burden of disease in all the world, and different color shows prevalence rate, and you can see that the highest rate, which is in red color, present in countries like in Africa, whereas the lowest is blue color, seen in some American continent, Australia and so on. India here is in mid positions as well as Russia. And we have one more slide showing why this disease is frequent. First of all, about 843 millions of humans, of people all the world, suffer with this disease is 217 years. Approximately 1 of 10 persons in the world suffer with this disease. And especially it is more prevalent in patients with diabetes mellitus, in women in comparison with men, in hypertension, in elderly, and in some racial minorities. In second picture you can see rate which will be increased with the time, its time frames given, and you can see it increasing death rate up to 40% since 1990 to 2017 years, and prognosed by 2040 years it will be 5th cause of all death in the world. It's very large burden, which is especially seen in low and middle income countries. What about precisely by different countries' prevalence? In USA, it is every 1 in 7 persons suffer from this disease. In European Union, 1 of 3 adults is at risk of chronic kidney disease, and especially 1 in 5 men suffer it, and 1 of 4 women suffer it with age more than 65 years. Highest prevalence in countries of Europe is seen. And after this information, of course, I was interested to find what about India statistics. Chronic kidney disease in India is more prevalent among male than females, and we have trend in prevalence which is increasing with the age. And at 10 years before, it was registered at about 63,000 cases with chronic kidney disease, and median age is more than 50 years. And depend on different states, you can see that south states are more suffered from this problem than northern in comparison with northern. This slide showing what role of chronic kidney disease among dying causes in patients in India, and the highest role you can see in these states which are given. So that it is very, very important topic and very relevant for all the countries as ours, as well as your country too. And before discussing what is chronic kidney disease, we must revise our knowledge about kidney. What do our kidney do? Of course, all we know that most people have 2 kidneys, and they filter our blood every minute per day, and about 1 blood comes through kidneys 40 times per day, and process of filtration is in progress. They are the hardest working organs in our body, which use 25% of blood from every heartbeat. What do they do? First of all, kidney make urine. Always students say this because it's very simple, because amount of salt and water retention, all this is function of kidney, but it's not single function of kidney. They also regulate blood pressure because they have renin, angiotensin, aldosterone system. They also control metabolic changes in bones and minerals like vitamin D. They also control metabolism and erythrocytes level because they produce erythropoietin, so that it is very important organs in our body. And 5 amazing facts about kidneys. They receive up to 25% of all blood pumped by the heart. They filter about 8 liters of blood in an hour, and just 1 donated kidney is required to substitute 2 failed kidneys. They produce active vitamin D, which helps the body absorb calcium, and kidney will continue performing until they lost up to 80% of function. It is very important moment that kidney continue working until they are dying up to 80%. We must remember this fact, and we will come back to this fact lately. In kidney, we have 3 steps of process filtration of the blood to urine. First of all, it is glomerular filtration. It's when nephron, functional unit of kidney, filter blood that runs through the capillary network in the glomerulars. Almost all solutes, except for proteins, are filtered out into the glomerulars. Second step is filtrate is collected in renal tubules, and this is tubular reabsorption process, because most of solution get reabsorbed, they are coming back, and others solution makes to be concentrate. It moves to the loop handle, its filtration continues to exchange solutes and water with the renal medulla and the peritubular capillary network. Water is also reabsorbed in this step, and we gradually move to step 3, which is tubular secretion. Additional solutes and wastes are secreted into the kidney tubules in this process, and collecting ducts they collect filtrate, which is present now, and move it to kidneys, to renal pelvis, and now it is final urine, not primary but final secondary urine. On the picture you can see all the process. So kidney you can see, and this is one structural unit, nephron. Nephron consists of glomerula, in which arteriola, afferents bring blood, and efferents take away blood. Filtration is present in glomerular capsula, and primary filtrate, primary urine coming to tubules. There are proximal convoluted tubules, then loop handle, then distal convoluted tubules, and collecting ducts which move urine to the kidneys. Let's continue and talk about what is chronic kidney disease. Definition. Chronic kidney disease is progressive loss of renal function over time. This leads to decreased ability to remove waste products from the body and perform homeostatic functions, and it is based on gradual decline of glomerular filtration rate and creatinine clearance. Diagnostic is based on 2 parameters: glomerular filtration rate, which is decreases and less than 60 milliliter per minute per surface body area, and presence of some kind of kidney damage, regardless the cause, for 3 or more months. You can ask why we have some interesting units, milliliter per minute per square surface body area. I will reply this soon when we discuss glomerular filtration rate, what is this? And now let's talk about causes and risk factors for chronic kidney disease. First of all, it's age more than 60 years, because elderly categories is more predisposed to this problem. Second, it's gender. Generally, women are at higher risk for incident chronic kidney disease, whereas men are more predisposed for end-stage renal disease. Then we have some racial and ethnic minorities which are more predisposed for this. For example, the highest incidence was found for African Americans, and for example, scientists found that Hispanics have higher incidence rate for end-stage renal disease than non-Hispanics. People with lower socioeconomic status face greater burden of chronic kidney disease, and they have rapid GFR decline. Then diseases which predispose are hypertension and diabetes mellitus. They give most cases of chronic kidney disease, whereas other diseases are rare. And of course, family history of the disease is one more risk factor. Have a look on this scheme showing role of diseases. Diabetes mellitus has about 44%, the highest role in development of this problem. High blood pressure, hypertension is about 1/3 cases. We also have glomerular diseases, polycystic kidney diseases, and some other causes which contribute to chronic kidney disease. All risk factors we can highlight modifiable and unmodifiable risk factors. Unmodifiable risk factors are age, gender, ethnicity, genetic predisposition, and one factor found is low birth weight. And modifiable risk factors are drug toxicity, hypertension, diabetes mellitus, hyperuricemia, dyslipidemia, autoimmune disease, obesity, urinary tract infections, and oxidative stress. What glomerular diseases can cause chronic kidney disease? They are diabetes mellitus, autoimmune diseases, systemic infections, drug intoxication, and neoplasia. Vascular diseases contributing are atherosclerosis, hypertension, ischemia, vasculitis, and thrombotic microangiopathy. Tubular interstitial diseases are urinary tract infections, kidney stones, kidney obstruction due to stones and other causes, and also drug toxicity may contribute here. Cystic diseases, it's polycystic kidney disease. We can think that only native kidneys are in risk of chronic kidney disease, but also history of kidney transplantation can contribute to this process. In addition to pathologic abnormalities observed in native kidney, common pathologic abnormalities include the following: chronic allograft nephropathy, rejection kidney, drug toxicity, specific medications which used in transplantation, virus nephropathy, and even recurrent diseases like glomerular diseases discussed before, and so on. Pathogenesis of chronic kidney disease. We have some initiating factors like diabetes mellitus, hypertension, and so on, which I discussed already. And what has happened next? Some number of nephrons is dying and decreases. This leads to activation of vasoactive mediators, cytokines, renin-angiotensin system, and we have structural and functional changes of surviving nephrons. They are overloaded with exertion, and this leads to hyperfiltration process. Hyperfiltration, we can think it is good when filtration is intensive, hyperfiltration, but actually it's not good because it's just stage of compensation of kidney which are damaged due to some causes. What has happened next? Next we can see increased intraglomerular capillary pressure, accelerated sclerosis of remaining nephrons, and decreasing in number of nephrons again. And we have vicious circle when number of nephrons is decreased, decreased, and decreased. And in some step, process compensation shift to decompensation. And after that, glomerular filtration will be decreased, and process is irreversible and unstoppable. In this scheme, we can see same first steps. Adaptive hyperfiltration is present, which stimulates renin-angiotensin system, which increased glomerular permeability. And what has happened next? When decompensation develops, we can see increased filtration of proteins and macromolecules, which leads to proteinuria and dyslipidemia, nephrotoxic inflammation, kidney remodeling, tubular interstitial fibrosis, and focal segmental glomerular sclerosis, especially in second degree, when we see typical clinical manifestations with decreased glomerular filtration rate, with decreased urine output, and with systemic complication. It is late course focal segmental glomerular sclerosis, it is late stage of the problem. What does it mean? Glomerular sclerosis means sclerosis, scar formation of the glomerular. There are no proper nephrons and no proper function here because of sclerosis. This is irreversible process when our help is just to make transplant of kidney. Classification. Each patient is classified into one of 5 following stages. The stages are stage 1, 2, 3, 4 and 5. In stage 1, it is when we have normal function of kidney or even hyperfiltration. In stage 2, we have mild loss of function. Stage 3 is moderate, 4 is severe loss of function, and in 5th stage is kidney failure. Why we recognize different stages? Because management and prognosis varies according to the progression of damage. And we are coming back to phrase about that kidney works until 80% of kidney died. It was phrase from the beginning. Now we can see that kidney have many stages, and in stage 1 it's 90 or more percentages of kidney function preserved. At this moment, patients have no specific symptoms, but kidney function can slowly decline. Patient move to stage 2. 60–89% of kidney function is preserved. Patient usually don't have clinical signs, but his kidney continue dying. Patient move to stage 3, you can see about 30–50% of function kidney is absent, and only at this moment patient develops first clinical signs of chronic kidney disease. He can feel some unpleasant changes associated with these symptoms, and he starts to treat properly. And what is problem here? That 1/2 of kidney at this moment is already dead. If he do nothing or he don't treat properly, we move to stage 4, when only 15, 28, 29% of kidney function is preserved, and here is kidney function which is very low, and treatment for kidney failure may be needed soon. And after that stage, patient quickly move to stage 5, when there is less than only 15% of kidney function preserved, and at this moment kidney can no longer keep up with removing waste products and extra water. This is called kidney failure. Although there is no cure, treatment options are available, and first of all, kidney transplant is recommended for these categories of patients. Here are clinical features with progression of the disease by the stages. And as I said before, stage 1, 2 and even 3 usually are asymptomatic. Water or electrolyte imbalance or metabolic endocrine changes are not clinically evident. Serum creatinine may be increased and urine analysis which is abnormal may be detected. But most disturbances manifest in stage 4–5. Edema and arterial hypertension may be the one early signs of chronic kidney disease. So in stage 1 and 2 we can see edema, facial, peripheral edema, maybe sleep disorders, and maybe high hypertension presence. Then stage 3, some symptoms may appear, and they are very variable. Maybe mental status changes like anxiety, depression, edema is worsens, constipation develops, edema present and worsen, as I said before, and hypertension usually also intensified. Why the signs appears? Because we have increasing burden of uremic syndromes starting from this stage. What is uremic syndrome? It's symptoms of uremia. What is uremia? It's urine in blood. What does it mean? Not urine itself, but urea, creatinine, and some other toxic products which are circulated in blood and don't removed by kidneys. They are toxic for the body, and they give some toxic reaction for brain, like encephalopathy, for another organs, so that variable symptoms appear here. In stage 4, we can see more severe symptoms with fluid overload, pruritus, fatigue, muscle cramps, restless legs, cognitive dysfunction, and nausea and vomiting due to intoxication. And in stage 5, which is final, which is very unfavorable, we have symptoms of deterioration like cardiopulmonary or gastrointestinal symptoms and symptoms of uremia, also present here. Edema, very typical and very early sign. Most often edema is mobile. It is detected on the face, on the eyelids, it is periorbital edema. It is usually appears in the morning and decreases in the evening. And this edema make puffy face, puffy pale face. Lips may be also swollen. Edema is local, it is not generalized, and it may be also the reason for seeking help for such complaints as difficulty breathing due to pleural effusion or laryngeal edema, substernal chest pain due to pericardial effusion, scrotal swelling, swollen knees due to hydroarthrosis. Have a look on this scheme showing manifestations of chronic kidney disease. At the beginning of scheme we see some abnormalities of kidney structure which leads to kidney damage. And we move with arrow 1, what has happened? Kidney tubules atrophy seen and kidney interstitial tissue undergo fibrosis, kidney damage present, and erythropoietin production is decreased. This leads to decreased stimulation of bone marrow and anemia. Anemia is one more manifestation for chronic kidney disease. Then toxic substance build up, they're present in bloodstream and they make toxic damage with decreasing erythrocytes and again stimulating anemia, and they also make uremic syndrome. What has happened next? We have decreased conversion of calcidiol to calcitriol in kidney. It's part of turnover of calcium in the kidneys. It is damaged here, and what does it mean? It leads to decreased calcium absorption from small intestine and hypocalcemia. Why hypocalcemia is a problem for us? Because when calcium level is decreased in blood, we have increased parathyroid hormone in blood. It is development of secondary hyperparathyroidism. And why this is problem for us? Because it develops mineral and bone disorders due to calcium is low and parathyroid hormone is high, and also vitamin D abnormality is also present because vitamin D is metabolized in kidney, it's part of its metabolism which is damaged in this process. And we are moving to next step, what is happened due to decreased glomerular filtration rate. First of all, we have decreased renal excretion of phosphates, and that means that level of phosphates in blood is increased. It is hyperphosphatemia. Hyperphosphatemia contributes to stimulation of secondary hyperparathyroidism, first of all. Next outcome of low glomerular filtration rate is decreased renal excretion of ammonium, increased anion gap, and metabolic acidosis. This is important moment because in treatment we will use some alkali measures for treatment of metabolic acidosis. Then, that's not all. Also, we have decreased renal excretion of salt and water, which leads to increased extracellular fluid, overload, and edema, pitting edema, which we discussed, hypertension also. And also kidney are failed to excrete potassium. This leads that potassium present in bloodstream hyperkaliemia. It's also very typical. Then, if we think that problem is finished, actually it's not. Due to chronic kidney disease, atherosclerosis develops more quickly, more intensively, and atherosclerotic disease makes to be systemic in most arterioles, large arterioles and vessels, and so on. And one more outcome is changes in metabolism exchange when we have lipoproteins abnormalities. And why so? Because lipoprotein clearance from blood is decreased and we have dyslipidemia with increased low-density lipoprotein, with increased total cholesterol, increased triglycerides, and decreased high-density lipoprotein. Diagnostic of chronic kidney disease. Laboratory methods. First of all, we can detect anemia. That means erythrocytes level is low, hemoglobin level is low. Anemia manifestate with fatigue, reduced exercise capacity, paler skin, and all other typical for anemia signs, while it develops due to erythropoietin. Then hyperkaliemia, potassium level in blood is increased. It manifestates with malaise, palpitation, and it is present due to kidney are unable to excrete it. Then hyperphosphatemia, phosphor is very high in blood and calcium is low, hypocalcemia. Why it is problem? Because calcium accumulates in soft tissue. It is decreased in the blood, but it is accumulates in soft tissue. It stimulates kidney stones, it stimulates atherosclerosis with calcium accumulation, and so on. And also osteodystrophy develops due to bone metabolism is damaged. Then parathyroid hormone is high, hyperparathyroidism develops with all typical its signs. Then for diagnostic we can have a look on creatinine level and urea level. They will be increased because they reflect kidney function, and as kidney can't remove some toxic substance, it is accumulated in blood. And glomerular filtration rate will be increased in early stage in compensation, it is hyperfiltration, and it is decreases in late stage, it is decompensation, it reflects kidney function. What is this parameter, glomerular filtration rate? It is volume of fluid filtered from the kidney glomerular capillaries into the Bowman capsule per unit time. It is the best overall index for kidney function. Normal parameter varies according to age, sex, body size, and declines with age. Normal result is about 120 milliliter per minute per some square area surface. Usually we say that about 90 to 120 it's normal range. There are different ways to get parameters glomerular filtration rate. We can calculate it to estimate with formula or to measure. And first formula which was given for checking this parameter is Cockcroft-Gault formula. It was developed in 1973 using data from about 250 men with creatinine clearance with ranges 130 milliliters. And it is not adjusted for body surface area, and at this moment this parameter is not used because it has not been expressed using standardized creatinine values. It was the first try of scientists to check glomerular filtration rate. So we can see calculators, online calculators for checking this parameter with different formula. It is available for the doctors, and you can see on the slide example of this online calculator. Next formula which is really used now is MD-RD formula equation, which is, you can see it is based on parameter age, creatinine level, gender, also specific indexes for different ethnic minorities, and it is calculated to normalized body surface area. It's 1.73 square meters. This parameter is unified, which helps us to detect how many creatinine is collected from the blood from some surface area, and it is accepted average adult surface area, and it is used now. And second frequently used formula is CKD-AP formula. It's creatinine measurement in milligram per deciliters. Two formulas are used and based on serum creatinine. And we can find online calculators for checking these parameters in our real clinical practice. Categories and stages of glomerular filtration rate. We have 5 categories of these parameters, depend on range of glomerular filtration rate. G1, it's first category, when we have normal or high level of GFR, it's more than 90. Second, it's mildly decreased when GFR is 60, 89. Then we have third category, having A and B subtype. A is mildly to moderately decreased, 45-59 years, and B is moderately to severely decreased, 30 to 44 parameters. Stage 4, category 4 is severe decreased glomerular filtration rate, 15 to 29, and fifth is kidney failure when GFR is less than 15. Albuminuria is one more parameter and one more marker for kidney damage. We have 3 categories of albumin level which are used for classifying chronic kidney disease. It's normal to mildly increased albumin level, moderately to severe increased, and severe increased albumin level. Depending on this, we have 3 categories with level of albumin and albumin to creatinine ratio, which make different prognosis and different tactic for this patient. Also, in urine, we must check sediment abnormalities because they may be markers of kidney damage. For example, RBC casts are detectable in glomerulonephritis. White blood cell leukocytes are detectable in pyelonephritis, in interstitial nephritis. Oval fat bodies or fatty casts are seen in proteinuria. Granular cast, renal tubular epithelial cells may be in some parenchymal diseases. Additionally, markers for underlying diseases we must detect. For example, if patient has diabetes mellitus, we must check glucose level, glucotolerance test, glycated hemoglobin, and so on. If patient has autoimmune disease, we must check additionally antibodies which are specific for particular diseases and to confirm diagnosis. Okay, let's move to uremia. What is uremia? It is clinical syndrome marked by elevated concentration of urea in the blood and associated with fluid, electrolyte and hormone imbalances and metabolic abnormalities which develop in parallel with deterioration of kidney function. Urea and other toxins accumulate in the blood and cause life-threatening problems, life-threatening issues. What manifestations of uremia? Ecchymosis and gastrointestinal bleeding appears. Why they appears? Because we have increased tendency to bleed due to uremia-induced platelet dysfunction. We can detect pericardial friction rub. It's due to uremic pericarditis, which manifestate chest pain and malaise. Mental status deviations develop, headache, confusion, coma in late stage. It's uremic encephalopathy. It's adverse effect of high urea concentration to the brain, to central nervous system. And skin pigmentation also changes, it appears. Why? Because skin partially takes over the function of the kidney in terms of removing urea and toxin. And skin have some brown discoloration like it's seen in this picture. This is typical uremic pigmentation in patient with kidney problems. Brown discoloration because blood is partially cleared with not kidneys but skin of patient. Diagnostic criteria. For chronic kidney disease, it is defined based on presence of either kidney damage or decreased kidney function for 3 or more months, irrespective of cause. So, first criteria is duration more than 3 months, which is based on some documentation, which is not words of patients, it must be some information objective. Then, glomerular filtration rate decreased less than 60, and presence of kidney damage as defined by structural abnormalities or functional abnormalities other than GFR decreased. To check kidney damage, we use instrumental method of diagnostic. It's imaging method, imaging abnormalities as markers of kidney damage, ultrasound, CT scan, MRI scan, usage contrast or don't use contrast, angiography. These methods can help us to detect structural changes like polycystic kidney, hydronephrosis due to obstruction, cortical scarring due to kidney infarcts, due to long-term pyelonephritis, or vesica-ureteral reflux, not reflex, but reflux, backflow of urine. Renal masses or enlarged kidney due to infiltration, inflammation, renal artery stenosis, and maybe small and echogenic kidney, which is seen in late stage of chronic kidney disease due to many parenchymal diseases. And of course, we must remember about instrumental method is checking blood pressure, because arterial hypertension, which is secondary due to kidney disease, it's early sign of chronic kidney disease. Natural history of chronic kidney disease, its progression of disease if we do nothing. How it progress? First category, if patient is normal and at this moment he has no any abnormalities and problem, and we can do only screening for risk factors. We can detect that patient is in increased risk factors, but at this moment he have no any problem and abnormalities. What we can do like doctors here to reduce risk factors and make regular screening. Then, next stage, if disease progress, it's appearance of some damage of kidney, damage of structure of kidney and damage of its function. At this moment, we have range of treatment measures, we can treat comorbid conditions and we can achieve real slow down progression. But if it's not happening, next step, it's severe decrease in glomerular filtration rate, when we estimate progression, and at this moment we treat mostly complication, and we must prepare patient to replacement, because next step will be kidney failure when they are unable to do something at all, and replacement by dialysis and transplantation is required. And if we do nothing here, death, it's final step of this disease. That's why it is very serious condition. For checking what treatment way we must have, we use classification table. It's international and we already partially discussed it. It's based on cause, GFR and albuminuria. In left side you can see scheme classification of GFR, which we already discussed, 5 degrees present, 5 categories. In middle size, we can see classification by albumin level, which we already discussed. And when we use its combination, you can see table showing us what to do in every particular situation. If patient has normal or mildly increased albuminuria and normal and high or mildly decreased GFR, this patient must visit doctor only 1 time per year. And usually we just work with risk factor, we don't treat because at this moment problem is absent. This value means how many times doctor must visit, patient must visit doctor per year to check parameters of kidneys. In yellow color it's gold color for treatment, because we have range of treatment if patient is in this category. And red color means that it's too late for treatment and we work with symptoms, and mostly we must refer patient to dialysis or prepare for kidney transplant. Let's talk about management and treatment approaches. You can see this scheme again. Upper half of scheme is discussed. We already said about symptoms, which appears in different stages. And now what about treatment in different stages? In stage 1 and 2 and up to 3 stages, we can use pharmacotherapy, we can use alternative therapy like diet, lifestyle modification. It's just recommendation for risk factor modifications and so on. At this moment, kidney preserving therapy and effective symptoms management may absolutely delay analysis and transplantation. In stage 4, unfortunately, it's impossible, and we must prepare for transition to kidney replacement therapy, usage dialysis, different types, and so on. Starting from this moment, we have mostly palliative care, supportive care, and being in hospice, because in final stage, patient depends on dialysis machine. She must clear his blood almost one time to 2-3 days, and he cannot live without it. We can do only this measure to help him until transplant of kidney find and to do this measure. How to treat chronic kidney disease? First of all, we must control protein intake and restrict salt intake. High proteins diet are not recommended because they predict end-stage renal disease, and also we must reduce dietary protein because it slows GFR decline. So that level of proteinuria can be 1 gram per day. Salt restriction, in one side it is recommended to do, in another side it's controversial recommendation. Anywhere we know that salt restriction is effectively for management hypertension, and hypertension is preserved in these patients. Next measure to do, we must control metabolic syndrome components and diabetes mellitus. Metabolic syndrome, obesity, they are risk factors, they are accompanied by dyslipidemia, which is not good for us, and diabetes mellitus is dangerous because high glucose level, it is stimulation of progression chronic kidney disease. And when we decrease and normalize glucose in blood, it will significantly slow progression of vascular diseases, and vessels are present in kidney. It's helpful for kidney. Then, if patient has smoking, he must stop smoking because cigarette smoking promotes progression of all forms of kidney diseases and chronic kidney diseases too. Then, medications used to control blood pressure. We also, before medication, must control some parameters in blood: phosphorus, potassium, creatinine, and urea. Usually, serum phosphorus does not elevate it until late stage, like stage 4. But we must control it regularly to find this moment when it is increased, when it is abnormal. And we must, first of all, reduce phosphorus intake. For example, we use a vegetarian type diet, which don't contain it. Or we can use phosphate binders, which are recommended. Usually they are aluminum containing medications which bind phosphates, and phosphates level decreases. Potassium level increased in chronic kidney disease, so that we must control it, and we must avoid food with high content of potassium, and we must avoid potassium sparing diuretics like spironolactone. And if required, we can administer loop diuretics because they make decreasing of potassium level. They stimulate its elimination. Then we must avoid and minimize nephrotoxic agents. Of them, non-steroids anti-inflammatory drugs, intravenous contrast, and maybe some antibiotics having nephrometabolism. They must be avoided, or they must be decreased in dose because they can potentially induce acute kidney injury on the underlying kidney disease and therefore exacerbate chronic kidney disease. Then we must administer nephroprotective agents. What is nephroprotective agent? It is ACE inhibitors and IRB. ACE inhibitors means angiotensin converting enzyme inhibitor. Why it is important? Because in kidney we have renin-angiotensin-aldosterone system which is hyperstimulated, and we block it with this medication. And one more is ARBs, it's angiotensin receptor blockers. These medications are very effective and they have nephroprotective effect because they block this RAS system. They are antihypertensive drugs also, but they're used even if hypertension is absent. Our goal in blood pressure is 120/80 and less if tolerated, and we start with mid-dose, and if blood pressure is not at goal, we can increase dose after 2-4 weeks, and if we did not achieve blood pressure level which is required, we use additionally calcium channel blockers, which are helpful us in these questions. And next, for controlling blood pressure, it's beta blockers and aldosterone antagonist. But I pay your attention that beta blockers should be used, and they are used mostly to manage coronary heart disease or arrhythmia. For hypertension, they are less appropriate because they decrease blood pressure not so intensively, not as intensively as in other medications. And we must be careful with aldosterone antagonist therapy, like spironolactone, like eplerenone, because they are firstly potassium sparing diuretics, and that means they increase level of potassium. In late stages of chronic kidney disease, we don't use it. Only in early stage when potassium level is normal. We must be careful with this parameter and control potassium level regularly. If possible usage, the usage of this medication is very good and very effective because they have substantial antihypertensive, cardioprotective and antiproteinuric effects even in low doses. Next, how to control edema. Our patients usually has edema, and to control it we use diuretics. What diuretics? Usually loop diuretics like furosemide, torsemide, but also we can use chlorthalidone, and they are it's not first-line therapy first of all because they have some metabolic changes in functions and we must be careful with them, but they're also useful when we must eliminate potassium because they effectively, like furosemide, they do it effectively. Next, treatment is alkali therapy. As we said before, metabolic acidosis develops. And to treat metabolic acidosis, we need alkali therapy. Recommended forms of it's sodium bicarbonate. Usually patients with late stages of chronic kidney disease are required infusions of sodium bicarbonate. It's course with daily infusions, about 7 or even more infusions, and they feel better, they feel the effect of alkali therapy. And except sodium bicarbonate, we can use sodium citrate. We can also recommend diet high in fruits and vegetables because it contains potassium citrate and so on. Generally, alkali therapy also improves protein nutrition by suppressing protein catabolism and protect against hyperkalemia. To treat anemia, we use, first of all, we can think that iron supplements are effective to treat anemia here. But we remember that here is main problem is erythropoietin is low, so that iron supplements may be not effective or partially effective here. So the treatment of anemia in this case is erythropoietin injection. Then our treatment must cover prevention of infections and treatment of infections. Infections is very serious problem for patients with late stage, especially end stage kidney disease. Why so? Because many causes leads to inappropriate function of immune system, and patient is constantly in hypoimmunity, in immunosuppression, and this patient catch infections very effectively, if we can say like this. So that we must use preventive antibiotics. For example, patient planning to to visit dentist and extract tooth, he must intake antibiotics. If operation planning, he must get course of antibiotic. And of course, treatment of presence infection with severe antibiotics are recommended because patient in high risk of infections. And we must also remember that chronic kidney disease increases risk of acute kidney injury, and in another side, acute kidney injury stimulate development of chronic kidney disease. Next method of treatment is dialysis. Dialysis makes it possible to continue living with end-stage kidney disease for many years or even decades. There are two main types of dialysis: hemodialysis and peritoneal dialysis. Hemodialysis is a procedure where a dialysis machine and special filter called an artificial kidney or dialyzer are used to clean blood instead of own kidneys, which doesn't work at all. To get blood into dialyzer, doctor needs to make specific access entrance into the blood vessel. It is done with minor surgery in the arm. Then dialyzer and filter, it has two parts. In one, it's for one your blood in one washing fluid called dialysate, and we have thin membrane which separates these two parts, and blood cells, protein and other important things, they remains in the body, whereas toxic substance, urea, toxic waste products which are present in blood, they are moving through membrane and washed away. Usually in countries and in cities have specific dialysis centers in which hemodialysis is realized, because it's not routine procedure. It is not in every hospital present, but only in specific medical centers. How quickly we must do this? Usually it's required 3 times per week, and procedure lasts about 4 hours every time. And this scheme showing what is happened. So it's patient hands and specific access for dialyzer. And we have first way, when blood removed for cleaning, it's moved to specific compartment with dialysing solution. Blood pumped, blood have also get heparin to prevent clotting, and dialyzer inflow pressure monitor present, and then dialyzer itself seen which process present, and used dialysing solution also, and then cleared blood is coming back with specific venous pressure monitor with automatic lamp. Finally, blood returned to the patient bloodstream. Another way is peritoneal dialysis. Peritoneal dialysis, in this case, blood doesn't cleaned outside the body, but it is process which present inside, in abdominal cavity. Abdominal cavity is hollow space surrounding the organs in the abdomen, and with the help of dialysis fluid, it is possible to do. Patients are given a special abdominal catheter. About 2 liters of dialysis fluid is transported into abdominal cavity through this catheter. After some time, this fluid is then removed and replaced with new dialysis fluid. Why it is possible? Because peritoneal area is lined by peritoneal cells, and they perform function as membrane. And this process is going through like membrane process. This type of dialysis can also be done at home, and this method is it is less effective, but it is more available method. 2 basic methods are used in peritoneal dialysis. We have standard method, it's called continuous ambulatory peritoneal dialysis, when fluid is manually exchanged 3 to 4 times per day and no machine is needed. But we must get extensive training from medical professionals to learn how to handle catheter hygienically and so on. The abdomen is always filled with dialysis fluid in this case. And if we don't want to exchange the fluid during the day, or we don't have this opportunity to do because work, patient or another causes, we can use automatic method of peritoneal dialysis. every night instead. Here, catheter is connected to a device called a cycler that regularly exchanges dialysis fluid. And this is a scheme showing how this works. We can see abdominal cavity on the slice scheme, and we can see catheter and fluid, dialysat, it's fluid to clean, and drain, it's finally what is evacuated from peritoneal area. And this is cells, mesothelium cells, which play a role of membrane. In one side we have peritoneal cavity, in another side peritoneal capillaries. And in capillaries, it's bloodstream, we have toxic substance which move to peritoneal cavity. And we have glucose, lactase, and some useful component moving inside to capillaries from peritoneal cavity. So that we have this exchange which make which help us to clean patient of his toxic substance if his kidney doesn't work properly. Kidney transplant. Next method, which used in 8-stage kidney disease, it is kidney transplant. Is the transfer of healthy kidney from one person into the body of person who has little or no kidney function. Who can have a kidney transplant? Most people who need a kidney transplant are able to have one regardless of the age, as long as they are well enough to withstand the effects of surgery, or transplant has a relatively good chance for success, or if person is able to comply with the recommended treatment required after the transplant, such as taking immunosuppressive medications, attending regular follow-up appointments, and reasons why it may not be safe or effective to perform a transplant. It's having of some ongoing infections, it must be treated firstly, or severe heart diseases, decompensations, cancers, tumors that has spread to several places into the body, or AIDS. Kidney donations. Unlike many other types of organ donation, it is possible to donate a kidney while patient is alive, because it's only one kidney is needed to survive. This is known as a living donation. People who want to be considered as a kidney donors are carefully tested to ensure that they are suitable for this procedure and are fit for the operation needed to remove a kidney. Ideally, living donations will come from a close relative because they are more likely to share the same tissue type and blood group as the recipient, which reduces the risk of the body rejecting the kidney. Kidney donations are also possible from people who have recently died. It's also known as deceased kidney donation. However, this type of kidney donation is slightly lower chance of long-term success. People who need a kidney transplant but don't have suitable living donor will have to wait until a suitable deceased donor kidney becomes available. They are in waiting list at this period, and usually at this time they are getting dialysis to prolong his life until they get donor's kidneys. And it's maybe duration lasts in 1, 2, 3 years, maybe more, it's different, but usually this method is effectively and it's very helpful for such patients. Let's conclude. What do we know about chronic kidney disease now? Chronic kidney disease, it is glomerular, it's disease with decreased glomerular filtration less than 60, with presence of markers of kidney damage at least 3 months. We have some specific formula for checking glomerular filtration rate, and we also have albumin level to check for this. It is important. We have some specific signs, specific and non-specific. For example, hypertension and uremia are early. Hypertension and edema are early signs, whereas uremic symptoms are late. Management of chronic kidney diseases depend on stage of disease, depend on risk factors and many others, and we must use different approaches in treatment. In early stage, we treat risk factors, we modify patient, we control him and make follow-up, we use range of medications with nephroprotective agents, with other methods, and in late stage we can do only hemodialysis, peritoneal dialysis and kidney transplant. But it is absolutely possible to achieve slow down progression and to avoid end-stage problems if we start treatment in early stage. And to do this, we must recognize problem in early stage. And this is absolutely possible to do if we are qualified doctors. And I believe that after this lecture, we will be these doctors. Thank you so much for watching. I believe it was useful for you. See you next time. Goodbye.